I'm Rick Sanderson. I'm the director of the Hallie Center for Healthy Children and Families here at OSU. And each year we have the Campbell Lecture, which is presented on the topic of risk and resilience in children and youth. And it's generously supported by a gift from the Campbell family, Duncan and Cynthia Campbell. We're grateful for their support of this series. It's my pleasure to introduce Neal Halfon today as the 2013 Campbell Lecturer. Neal has an MD and an MPH. He's director of the UCLA Center for Healthier Children, Families, and Communities, a name remarkably similar to ours, but one which emerged independently. He is also professor of pediatrics, health policy, management, and public policy at UCLA. And as we strive as a college to build a transformative vision for the future in public health, there would be no question among the selection committee that Dr. Halfon was exactly the kind of thought leader we wanted to attract in integrating our College of Public Health and Human Sciences. And the reason for that is that Dr. Halfon, as you'll see, has been doing really revolutionary conceptual work that's attempted to define a developmentally focused model of health prevention across the life course and to understand the implications of health, life course health development for the delivery and for the financing of health care. We're going to hear much more from him now. Thank you, Neal, for being here.
Let me get wired up here again. Can you hear me? In the back, everybody can hear me? Okay.
I don't know if it's on. It doesn't sound very loud.
They told me how to do this.
There's more sound now. Yeah. Yeah, there we go.
How's that? Is that better? Okay. All right. Well, it's great to be here, and I met Rick about 10, 12 years ago at a conference in Ohio and realized that we were both people who had a passion for life course studies, and it's great to be here and be able to actually spend some time with him. And I met Megan McClellan last year, roped her into an experimental sort of network of people that are trying to create knowledge in a new way. And I'm really thrilled about the way that this new educational venture is moving. What I'm going to do is I'm going to talk about the pressing need to transform our health system in the United States and the opportunity for children to be leading the way. I'm going to talk a bit about the new science and paradigms, specifically of complex systems analysis and life course health development. Then I'm going to introduce this 3.0 transformation framework as a way of thinking about how do we begin to transform our health system. How do we prototype 3.0 systems change? And making 3.0 goal of health optimization real. Actually, how do you do it? How do you make it not theoretical, but actually how do you do it on the ground, and where is it being done? And we have a big problem in the United States, as most of you know, and it's not just that the Republicans hate Obamacare. The big problem is that we have the most inefficient, low-value, low ROI healthcare system in the modern world. And we have this goal right now called the triple aim of improving population health, and improving the quality of care, and decreasing costs. So this is the mantra that's driving things forward. How do we improve care, lower costs, and improve quality in the system that's very inefficient? We have many other challenges, though, because we have enormous disparities in both health and health risks. We have rapidly rising chronic disease rates. We have unavoidable major demographic shifts, and we have these relentless cost increases that basically have been unresponsive to anything that we've tried to do. And there's a structural organization operating system problem that is why we have the cost problems that we have. And so we have this anemic and tired health policy strategy that doesn't reflect what we know about producing health, and we have an old and outdated operating system. And these are just some things you probably have seen before, but this is just to show that per capita healthcare spending compared to other countries were, twice as much as most other countries with not better outcomes. This is just showing healthy life expectancy at age 60, and you see we're doing better than a few countries, but we're down at one end of the curve. This is looking at access because of cost issues and that we have bigger problems in terms of having access. This is just looking at electronic medical records, and we think like we're the place where the internet was invented and have all the great, but you go to almost any other country and they have electronic health systems that work in ways that ours doesn't. And the list goes on and on and on in terms of this. We also know that the biggest cross drivers right now for healthcare or chronic disease, we're spending 75% of our healthcare dollars on chronic disease care and probably 83% of the Medicaid dollars on chronic disease care. And it's important to recognize this because I'm going to be talking a lot about children's health, and we spend a very small amount of our overall spending. In fact, children's health care expenditures in the United States is a kind of rounding error on the rest of what we spend, recognizing that we're spending the equivalent of what the eighth, or I think it's the ninth largest economy of the world is what we're spending on health care in the United States. It's bigger than the economy of France is what we spend at present. And we're not getting much bang for the buck. So chronic diseases are really driving a bunch of this. And what we see from this is that when we start looking at chronic disease prevalence, you see this big increase that is taking place. And mental disorders, and I'm going to come back to that this is really important, that how mental disorders are increasing in our population. You see hyperlipidemia. Some of that's a Lipitor effect, obviously, right? Because we've come up with a new drug so that, now everybody has hyperlipidemia. But you see in hypertension, diabetes, and other things, you see these big changes that are taking place. And this is what's driving a lot of the cost issues. The Institute of Medicine just recently did a report, which I highly recommend, on the international comparisons. This was commissioned by NIH, and it was looking at why the United States is the sickest of rich countries, why we have shorter lives and poor health than all the other industrialized rich nations in the world. And it went through and was trying to unravel this, but one of the conclusions it came to is that our children aren't doing as well as other nations. And this is very obvious here in the Child Wellbeing in Rich Countries report that came out from UNICEF. And this is the 2013 version. There was a 2009 version, I think, that came out. It was on Valentine's Day in 2009. And what you see here is 46 different indicators of child health and well-being. And you see where the United States is right at the very bottom. With overall ranking, we're better than Lithuania, Latvia, and Romania. So that should make us feel good. But, that our health care for children, the health measures, were actually right at the bottom. And one of the things I just want to point out parenthetically here, and it's if we have time for discussion, we'll go into this, but you see that Canada and the UK are actually in the bottom half, and there's a reason why the English-speaking countries are in the bottom half, and it has to do with the fact that our health policy for children, and our children's policy, is still linked to the Elizabethan poor laws. And that all the English-speaking countries have this sort of ideology that's built into their social programs of actually waiting for children to fail until we make payments. So we pay for failure in our country where other places invest in the success of their children. And I'll come back to that. So when we look at these rankings also, if what you were to rank a whole variety of other health indicators, what you would see that at for adults, they're the same ranking, so that adults in Norway and Netherlands and Sweden have better life expectancy and all of that. So in a sense, the die is cast early in the lifespan, and the reason why we're sort of seeing these big differences have to do where people start and continue along. Another point on this that's important is the UK and the United States used to be exactly linked. In the 2007 report, we were both at the bottom of the barrel. In fact, the UK was at the very bottom. But the UK has made a massive investment in in children to end child poverty over a generation, and they're pouring lots of money into their children right now. So when we look at how children are in the United States, well, the trends are good in terms of mortality. There are less children dying, and their morbidity is decreasing for many medical conditions, so that we have less kids hospitalized for pneumonia and gastroenteritis and various things. But disparities in health outcomes are increasing because social inequality is increasing. And we have this emergence of these new morbidities and concerns, especially obesity and mental health and ADHD and autism and the like. And the patterns of exposure and risk are changing. So we have squeezed families, and that's not just poor families, but all families are squeezed at this point for child care and health care and services and various other things. You have lots of hurried children because these children are now competing with every other child in the world for jobs, and lots of toxic environments, not just chemical, but emotional and other kinds of toxicity. And so we're witnessing this change that has taken place, and the obesity epidemic is just one way. But these increasing chronic problems to 16, and if you include obesity as a chronic health problem, it's about 33% of the population. Children have chronic problems, and it's not hemophilia, cancer, and congenital heart disease. There's growing prevalence of mental health disorders, greater appreciation of behavioral learning and developmental disabilities, and growing number of children with multiple conditions, multiple comorbidities. You have to ask, why is asthma, ADHD, and obesity traveling together? Why do the same kids have that? Is it just happenstance? There's some reason why that's happening, right? And what we look at disability rates in the United States, this is work that Paul Newacek and I have been doing for the last 25 years. It's sort of monitoring disability. What we see is in 1960, disability, you had 2% of the children that were disabled, and now we have close to 8%, and it's continued. We've continued on to 2011, and it just keeps going up. And what we know is that in 1960, the person with disability was a little girl. The poster child would have been a little girl with crutches and braces on her leg who was a polio survivor. And what's the poster child now is a child with autism, right? A lot less visible to us. A child with mental health problems, anxiety disorders. So when we look at children at risk, we have 4 to 6% of children with severe disabilities, and those are the kids we usually go after in our pediatric world, where we screen and we try to get them into the IDA, Regional Center Developmental Disability Programs. We have 12 to 16% of kids with special health care needs defined by the Maternal and Child Health Bureau as having more than average medical care issues. But we have about 30 to 40% of children that have behavioral, mental health, and learning problems, or significantly at risk for these problems, that they need more than average care than what a pediatrician would normally provide. And you have 50 to 60% of kids that are good enough, right? So, and how many people here have children? Okay? And when you look at your kids, do you say, well, you're good enough? Well, if you have teenagers, you do, right? I have 2 teenagers, and I say, you're good. You don't need that new thing for your, Xbox or iBox or whatever, But the issue, I put good enough up there somewhat, facetiously, because, that's what we think we have 50 to 60% of kids are good enough. We don't measure how our children are doing other than which ones are failing or which one have diseases and disabilities. We don't know what percent of children are thriving. Is it 30%, 40%, 50%? If you don't measure it, you don't manage towards it. So as you're setting up the health system of the future here in Oregon, you should be thinking about what your data system should be like, and do you want to continue to measure disease, or do you want to measure health and thriving and optimization of health? So what we know is that economic adversity is one of the things that really is horrible for children's outcomes, and kids that are born not just 100% of poverty level, but 200% of the poverty level are born earlier, smaller, more fragile, and are at risk, worse physical, cognitive, emotional health, going to be hospitalized more for a variety of problems, have lower health trajectories, and have more brain drain. And what I mean by brain drain, people are losing their brain capacity early in life. They're not, developing in ways that they could be. And I'm going to show you that. And they carry this burden of their social status into adulthood, and it's programming into their biology. It's embedded in their immune system, endocrine system, their neurologic systems. They're carrying this all forward with them. Right? And it doesn't go away. And so And we know this, and this is a famous Hart and Ridgely study. I was talking with Megan about this earlier today. And what we know, and this was an intensive study looking at kids and their development and vocabulary development early in life. And you see college-educated versus welfare parents with working-class parents in between. And by 16 months of age, you see this disparities start to develop, and by 36 months of age, you have this twofold difference in vocabulary. So you're just sort of projecting out what their SAT scores are going to be, right? And you're looking at vocabulary development, but what you're really looking at is brain development. You're looking at the functional capacity of these children's brains to process information. And what we know is 48% of our children are living below 200% in the poverty level. We know that 40+% of our children are in single-parent families. They're living in adversity. Okay, that's a huge number of children, right? So when we talk about kids at risk, we have a large percentage of our population on the risk. And the problem is you're not going to see all the problems in them unless you look, and they'd only become manifest later in their lives. As they become disabled adults. The largest cause of disability in the United States for working age people 18 to 48 is mental disabilities. Those people with mental disabilities end up becoming people with chronic health problems as they get older. So we have 48% of the children that are living below 200% of the poverty level. And this is from some data that we just did on from the ECLS, the Early Childhood Longitudinal Survey of Birth Cohort. And this is basically, I showed you the Hart and Ridgely studies, which were done, I think, on 74 or 120 kids. This is on a national sample. And what you're seeing is the social gradient. And you're seeing that we have these, it's not just rich and poor, but we have these very steep gradients. And it's really the gradient that we need to be thinking about. It's really, how do we shift these gradients? And if you look in other countries, and if I was to show you in Sweden or Norway or other countries, what you would see, they have gradients also, but they're much flatter, okay? So they have much flatter gradients. Please, there's a seat right there for you, right there. That's a friend. She's a friend of mine. Yeah, okay. I've heard that. So what we know is that when early childhood doesn't go well for you, that by the second decade, what you see is school failure, teen pregnancy, criminality, substance abuse, anxiety disorders. By the third and fourth decade, obesity, elevated blood pressure, depression. By the fifth decade, there's links to chronic disease and diabetes, renal disease and arthritis. And by the old age, premature aging and memory loss. What I would argue to you, not just to be provocative, that Alzheimer's disease is a disease of early childhood. That actually what is happening is the full number of neurons that you're going to have and use, and that some of that capacity is being developed early on. We sort of see it sort of tail off because the potential is being lost earlier. I'm going to come to something to show you how the English are looking at this as well. So that we see this sort of cascade of effects of what's happening early on. And what we know about our health system for children and our social service, our early childhood system, is it's fragmented. We know that there's difficult for parents accessing services. We know there's low and uneven quality. The models of care are outmoded. There's limited local responsibility, and it's operating under enormous constraints. And there's study after study, and I think the studies on the quality of care for children are rather dramatic, that the quality of health care for kids in the United States is actually worse than quality of health care for adults. And so what we have are these ideal trajectories in the current practice, and we have this enormous missed opportunity. And if anything, the United States has been about for, its full 200 years, is about providing opportunity to people. And so that we have this real unevenness in the opportunities and how they're developed. So we have these challenges and but we also have new paradigms and new strategies that are emerging. So I'm going to shift gears, and I've talked about the problem and this whole issue about what's building up in the sort of lifespan when children aren't dealt with in the ways that they need to and don't have the opportunities they need. But there's new paradigms in systems biology and health development and health care delivery that I think are actually provide new answers. So one of the things we've been interested in, those interested in human development, is this arc of human development and sort of what happens during that arc. And there's increasing that we're starting to look about that, not just as human development, but in terms of health development and how we're linking what happens early on in life and what happens to you later. This is just an ad from 10 years ago, Blue Shield, sort of making people think, they want people to buy their product and they want people to say, hey, we take care of you over the lifespan. But what we know, what's happened over the last 100 years is that the life expectancy, the lifespan has increased. So we went from 45 years life expectancy 1900 to about 80 years. What's also happened is the health span has increased so that people are living longer and healthier, but not, I'm going to argue, not as healthy as they should be. And we also have a higher performance span. You know, the IQ of the population has gone up by about 12 to 15% since the 1920s. You wouldn't notice that, or you wouldn't think about it if you read the paper, but in fact it has. So performance has increased, you know, and it's just not, the number of gold medals and, people in the Olympics and breaking records, but performance of human beings has increased. And we also know a lot about what determines these trajectories, so that we know people can go on a high trajectory or low trajectory. The number of risk factors they have push their trajectory down. The number of protective factors they have push it up. It's a kind of simple model, but it's the data sort of bears it out. The problem is when you go into a low trajectory, you become symptomatic at 55 or 60, and so you're obese and you have mental health problems, your family's falling apart, and you're starting to pay a lot of money for them, versus becoming symptomatic at 80. There's a huge delta there in the amount of money that we're spending on health care during that time period because we're not optimizing the health development of the population. And we know there's lots of multiple interacting influences. We also know that those influences aren't the same across the lifespan, so that they change, So families and school and daycare are important in your early childhood, but as you develop individual behaviors, they become more important. At the end of life, there's more dependency, so the family becomes important. And we know that these, if kids are going to go into delayed or disordered trajectories, we know that it's poverty, lack of health services, toxic stress, and we know that kids that go into better trajectories get more of those protective factors. So from a public policy standpoint, if we're working in a community, how do we increase the number of protective factors and reduce the number of risk factors? Especially if you have 40% of your kids in this at-risk category. From a population standpoint, this isn't about individual children. It's not about screening anymore for the individual child. This is about putting in levers that actually start to shift these curves. We have to become curve shifters. Like in Harry Potter, there's shape shifters. We in public health and healthcare have to become curve shifters. And the other thing is we have to realize that these are not simple problems. So this is from the Sinefin, sort of framework that's used in complex systems analysis. And you have simple problems, complicated problems, complex problems, and chaotic. And there's math that goes with all this. I'm going to spare you the math. But, mechanical pumps simple, or providing immunizations is simple. And a lot of the research we do is simple, because we're still looking at sort of, simple cause and effect kinds of things, and then categorizing what we see. An airplane is complicated, or managing or treating asthma in children, or treating leukemia. Those are complicated issues, okay? Multiple pathways, multiple levels. Complex issues are human development, community development. These are, and wildfires, chaotic. I'm going to stay out of chaos today. We build simple systems. You design and construct those that are more complicated, but these grow and develop. And the way that you understand these systems, the way that you sense them, the way that you probe them, the way that you research them is completely different. And we have too much of our work is still in this kind of simple category. And we try to make it all simple, but when it's not. And when we think about how complex systems work, and I'm not going to give a talk on complex systems analysis, but it's really understanding that you have simple behaviors, but you have these many components at many levels that lead to self-organizing kinds of activities that lead to the emergence of certain kind of phenomena. The work I'm doing right now for the Health Measurement Network for NIH is we're talking about health as an emergent capacity of human beings. It's not just a capacity, it emerges in a way out of a whole variety of factors that aren't always predictable. And it's sure not linear, okay? And so, but we continue to use lots of linear models and fancy linear models, fancy linear regression, but it's still linear models for the most part. But what we've seen is an evolving conceptual framework about how we understand health. So we started with, germ theory way back when in the 1800s, and medical anatomic looking and, someone had a tumor, well, that must be what, caused the problem, and simple gene models, and that led to the biomedical model, right, which was simple, mechanistic, and linear. And with the Framingham study, the Alameda study, and all the social epidemiology, we started to understand that there were multiple risk factors for cardiovascular disease, diabetes, and other things. And the behavioral sciences told us a lot about smoking and eating and all the kinds of stuff that, behavioral psychologists do. And that led to this biopsychosocial model, right? And the biopsychosocial model is more hierarchical, dynamic, and multiple determinant focused. But what's happened in the last several years is this research on lifespan human development, and life course sociology, and neurodevelopment, and the kind of stuff that Rick and Megan and others are doing. This is informing a whole different way of thinking. And when you bring the epigenetics and the developmental origins of adult disease and the life course chronic disease epidemiology, we're coming up with this new model of life course health development, which is complex, relational, dynamic, and developmental. So it's a very, very different way of thinking about how health develops. And what we know on the biological system side, on the basic science side, we're going through a similar kind of thing where we went through from Darwinian and Mendelian genetics. With population genetics, we went to this neo-Darwinist synthesis. When I went to medical school, it was all about one gene, one phenotype, right? It was, DNA, mRNA, one protein. They were all, and it was all linear. Well, we don't believe that anymore. I mean, some of it works that way. But what we know from systems biology and genomics and biocomplexity, the post-genomic synthesis is all about gene networks and how gene networks interact at multiple levels and stuff. So our science is changing rather dramatically. And these two things come together, so this post-genomic synthesis and the life course health development is being driven by the epigenetics and DOAD and complex system stuff, so you're coming up with this new health development model. This is where we're headed. And the important thing is, as you're putting together a new health college and thinking about things, sure shouldn't be biomedically focused or biopsychosocially focused. You should be thinking about where this all is going and where the science is headed. So what's coming out of this life course health development model is that health is an emergent property of living systems, that health develops continuously over the lifespan, so that health is continuously developing. It's not a fixed capacity. It's not the WHO definition from 1946. That health development is a complex, non-linear process that results from person-environmental interactions that are multidimensional, multidirectional, and multi-level. That health development is highly sensitive to timing and social structuring of environments, okay? And it's that timing and social structuring that I was talking about, and the sensitive periods issues for children that are so important. That evolution has enabled and constrained health development pathways and plasticity, that optimal health development promotes survival, but it also enhances thriving and protects against disease. So how do you optimize health development? And how do we deal with the timing issues, the cadence of human development, the timing of molecular, physiologic, cultural, and evolutionary processes? Just to be provocative, we're seeing this huge increase, right, in mental health problems in kids now, and especially in teenagers. Well, why is that happening? We talk about the obesity epidemic and how we're walking around with Paleolithic metabolism in a 21st century world, and how our metabolism wasn't actually engineered to deal with Big Macs and French fries, or when I go with my kids to In-N-Out Burger and they get monster fries, it's just like we weren't geared for that, and that's why people are getting fat, right? But when you think psychologically, in terms of our psychological development, what's gone on? Well, we had something called puberty, and we have something the culture created called marriage, right? Reproduction. And for I don't know, 20, 30, 40,000 years, puberty at age 15 or 16 when it happened, 14, 15, 16, and marriage, reproduction, were within 2 or 3 years of each other. And what human cultures did is they created religion and families that wrapped around that to keep that time of psychosexual vulnerability sort of protected in some way. And as what's happened is, as we've changed, puberty right now is what, at 11 and a half? And marriage now is like 25. So we've created this period of psychosexual vulnerability, and religion and family is unraveling, right? And so what's protecting that psychosexual vulnerability of children right now? And, you know, who's influencing it? Where's their anxiety coming from? And I'm not sure, I'm not sure that that's the answer, but we need to be thinking about these timing issues and evolutionary time frames and developmental time frames and what's happening. So when we look at these principles, we put these up not as principles like this, but this is a network of interacting principles. We have new principles down here so that, you know, one of the things your college should probably do is think about, if you're going to be in this world of life course, what are the other principles of health development? How do we use these to start to define what we're doing and understand what we're doing? And I just show a few pictures here to indicate, what I'm talking about. So we see these trajectories. This is brain development and how the brain grows. This is looking at glucose metabolism, synaptic density. What you have down at the bottom here is days after conception, and they're about, this is 14, 16, 18 years of age. And what you're seeing is this trajectory of actually how the brain cells are developing and using and being laid down. And so you see these trajectories developing. We also know that there's multiple experiences and adversity, and this is from the adverse childhood experience studies, or adverse childhood. So that if you experience adversity and you have multiple adversities early in life, the chance of having depression goes way up, or the chance of having heart disease goes way up. We know more about these time-sensitive pathways, so that if you experience toxic stress as a child, it affects the epigenome and it affects the endophenotype, not the phenotype, but the endophenotype, so that how it affects the midbrain in terms of affiliation and attachment development, the prefrontal cortex in terms of executive function and impulsivity, how it affects the HPA axis and stress response. And all those things are connected, and you see it in health behaviors and mental health and lots of chronic diseases. So we understand these pathways. We don't understand everything about them, but we understand that there's connections here, and we're getting better at potentially having biomarkers for those endophenotypes, right? There's some I just was at a really cool, up in Vancouver, they took some of the David Old's nurse home visitation data and looking at the effect on the epigenome and looking at DNA methylation in the people that got the nurse home visiting program when they were 1 and 2 years of age, looking at them at 40 years of age, and they have different methylation patterns, as a result of the intervention they got. So we're going to have biomarkers in the near future to look at all of this. And again, if you're designing for what the health system, be thinking about where we're headed. You guys are in a real Wayne Gretzky moment, right? The Wayne Gretzky issues that, why he did so well is he skated to where the puck was going to be, not where the puck was. So you need to think about where's this all headed. So, and we know a lot about, if we're going to optimize trajectories, we know that children, family, neighborhoods, this is what you guys are all about, right? There are all these multiple sectors that need to be brought together, so that you need these multi-sector approaches if, in fact, you're going to move stuff forward. And I just show this because I love this slide. It's from the Foresight Project in the UK. And what they were looking at, I know I'm walking off camera, but what they're looking at is the beginning of lifespan. Here's biology, people, mental capital, culture, and environment. They're looking at all the things of maternal care and stress and teachers and what's happening in stress and the experience. So they're looking at the development of mental capacity. These were 200 scientists that wrote 60 papers, and they integrated and synthesized this all together because they were interested in the waste of mental capacity. And if they could flip this 5 years or 8 years and decrease the Alzheimer rates by figuring out where they were going to have the greatest leverage. So this is just another example of this multi-level, multi-dynamic way of thinking about this. So when we think about this and how we transition this into how the health system works, here's another story. Okay, so I've talked about life course, and I've talked about life course development and complex systems and how we need to be thinking differently about what we're doing. Well, we've got this other sort of scenario going on. Our health system hasn't been stagnant. You know, it sucks, but it hasn't been stagnant. And so we've had three eras of healthcare, and we're in the transition in this third era. The first era was focused on saving lives through acute care, emergency care, rescue care, public health safety. That was the first era. Second era was focused on prolonging life and decreasing levels of disability through chronic disease. Third era is going to be about optimizing the health of the population. First era, people were only living to be 45. The second era, they're living into their 80s. You know, third era, they're going to live beyond. When you've seen the ads up now, I think, you know, that 1 out of 3, 1 out of 4 kids born today will live to be 100. Now, if they're living to be 100 and getting pretty sick at age 60, that's going to cost everybody a lot of money, right? So and I just wrote a piece in the New England Journal a couple months ago about the Medicaid system. With the change of the ACA, Medicaid is now a lifelong health program, right? People are going to start on Medicaid at birth and will be on Medicaid for life because we have no social mobility in this country also. That's, you know, that 40-something% of the people, 43% of the people born in the bottom quintile of the population will remain in the bottom quintile for life. So they'll be on Medicaid for life. So 8% of the population will be, and they're not going to be the healthiest campers, right? So we're starting to understand, you know, these sort of long-term effects and what we need to be thinking about. So here's a different way of looking at it. And so the first era focused on acute care and infectious disease. It's really driven by the biomedical model. It's about short time frames. People have an MI, they come in, they take care of them, they have diabetic ketoacidosis. It's all short time intervals. And that's where we create our medical care system and our hospitals and our clinics, and we create insurance-based financing because we have a fiscal vehicle that deals with short time horizons for unexpected events. That's what insurance is for. And we use an industrial model based on the kind of cottage industry of doctors' offices and hospitals, and that's why most big hospitals look like big old factories, right? And that's how they're organized. And the focus is on reducing death. As the epidemiologic change happens from 1900 to 1950, we go to 65 years of age, and we have increasing rates of chronic disease, and we create the NIH, which is just the Chronic Disease Institutes, right? We move to this biopsychosocial model because of the Framingham study. We create longer time horizons that we now have to manage over. So the doctors are no longer physicians and healers and doing immediate stuff, but they also have to manage care. They have to manage costs. They have to manage quality. So doctors have to be, the health system has to be managers over the longer time horizon. It's about chronic disease management. We change the financing model. So we go to prepaid health benefits, right? Because we know with prepaid health benefits, we know that you're going to have a pap smear or a prostate exam, so they're not unexpected. And we're moving towards this corporate model. What ACOs are in the Affordable Care Act, the corporatization of healthcare. It's putting everything into a vertically organized healthcare system so you can control production. And that's all that's about. It's, you know, how do you corporatize it so that everything looks like Kaiser or Geisinger, like these corporate entities. But where we're headed is towards increasing focus on achieving optimal health. And so we're moving with, the chip is changing, right? We're upgrading our chip from the biomedical, biopsycho, so the new explanatory models, life course health development. It's about lifespan and generational kinds of time frames and investing in population-based prevention, and we need new investment vehicles. I'm actually spending this year at the Federal Reserve Bank as a scholar there, and we're looking at what kinds of new financing tools can we use to invest in health capital over time. Health insurance can't be dead, because health insurance wasn't designed to do that. So what we've done is we've gone from this 1.0 to the 2.0 to the 3.0 system, right? And the United States is about 1.5, 1.8. Most of Europe is about 2.2. And again, I think you guys have to decide, are you going to be about 3.0 care, or are you going to be about 1.8 care? You know, do you just want to go from 1.7 to 1.8, or you know, what are you managing towards? As I was telling Rick, there's one of my favorite stories about innovation. Do you know who Václav Havel was? He was the president of Czechoslovakia. He was a playwright and kind of man in the arts. When he became president of Czechoslovakia and oversaw the sort of rebirth of that country, they had to put a new phone system in place. And AT&T came to him and said, we got just the phone system to you. We're going to sell you, you know, and basically it was all old equipment they had in a warehouse somewhere. And one of Havel's friends was this guy named Frank Zappa. And Frank Zappa was from the Mothers of Invention. A lot of people won't know who he is, but anyway, he was this kind of wild, crazy 60s music guy. And Zappa said, don't buy that crap from AT&T. He says, go cellular. He says, you don't want that old, you know. So you got to think about, do you want to go, you know, what are you going to start investing in at this point? So when we look back at the same model, the point here is just to show you that the 1.0 system is about biomedical model. The 2.0 system's here, and where we're headed is this 3.0. Right? It's this post-genomic life course health development model. Now, the reason why this ends up being explanatory in some ways, there's our trajectories again, and we know most of the actions here. We become symptomatic here, and this is what the cost curve looks like. All right? As you get sicker and sicker, the costs go up. And if you go into the higher trajectory, you have a different kind of cost curve. And what I'm showing there is we're investing more in that higher trajectory early on, so we have a different cost curve. So our 1.0 care, where lots of people making lots of money off of 1.0 care that don't want to change what they're doing, right? Lots of people making lots of dough off that. We're moving towards more 2.0 care, which is moving upstream, both in terms of the time frames and social determinants. 3.0 care is going to move up both the lifespan and in terms of what's going on. And the important point here is the rallying cry around health reform is all about bending the cost curve, but where they're trying to bend it is here. And I think that that's a fool's errand. I think that what we should be about is about shifting the health curve in order to shift the cost curve. Don't just try to bend it by sort of dealing with the, you know, making 1.0 care more efficient. So this is what CMS came up, which was their adaptation of this model, the 3.0 model. So they basically came up with an adaptation of the model to sort of say what this would look like. And right now, I was just on the phone this week, the state of Vermont and the state of Michigan is trying to design 3.0 systems through the state innovation model grant. I don't know if the state of Oregon's got one of the CMS grants to do SIM, but we've been talking with David Labby and Care Oregon about some of the, you know, how do you start doing sort of 3.0, you know, models and moving stuff forward. So we've been using this health system transformation framework, and it's just a sort of how do you make this real? So part of it is you've got to change the logic. So the new operating logic is, you know, how do you define health? How do you move this forward? What does it start to look like? How do you organize the health sectors differently? So our current system, you have these vertical silos, and you have all the mental health and early intervention that's all outside, funded by a different thing. It's not connected. Someone was just telling me, you know, they're in some part of Oregon, and they can't get the mental health and the health people to even be in the, you know, the women with depression who are screened can't get the services because they're all in separate systems. It's designed that way. System's designed not to work. So how do we change the design? How do we start to think about what does a new design look like? So what does a 3.0 system look like? How do we integrate some of our population health funds? How do we have integrated funding mechanisms? How do we start to redesign the system? It's a design problem, you know, and you need to have designers sitting with you, not just doctors and insurance guys, because they'll never come up with a new design because they don't know how to design. They know how to pay and take care of people. They think they do, but they don't. So how do you redesign this? How do you create better measurement systems? And how do you create a different kind of value portfolio? So the issue is, is a design problem. And we can think about how we integrate all this and make this all work. And this is what a lot of the European countries are moving towards. But, and actually I was just talking with the state of Vermont, working on their community health teams and primary resource centers. They're moving in this direction. So we also have to think about how we organize delivery of care. And I just show this because, if we want that higher trajectory, what I have here is the nurse home visitation program, pediatric medical home, reach out and read. It's just showing different programs that you need. But it's a design issue because all these have to be horizontally linked. They have to be linked together, and they have to be longitudinally linked. And when you do that, what have you done? Well, you've built a scaffolding around this higher trajectory, right? And just like this building was built with building codes with a scaffolding because of earthquakes and storms and stuff so it won't fall down, we know what the building code should be for building children's system. And unfortunately, we have children living in neighborhoods where earthquakes roll through their lives on a daily basis. Now, but we're not building the systems and the scaffolding to support them in a way that we know. So those are designed. Same thing with the pediatric office. If we're going to do more developmental services, we're pretty good about doing acute care and connecting to the acute care is about the doctor's office being connected to the hospital and the ER. Chronic disease is about being connected to the specialist. But if you're going to do preventive care and you're going to screen kids for development, you have to be connected to all this other stuff. And most doctors' offices aren't. You connect them all up. We know how to connect everything else, but why aren't we designing and connecting things up? Same thing with our 18-month visit. Right now we're screening for disabilities for 46% of children, but we need to be optimizing development. You have to actually look at the 30 to 40% of the kids that are coming in, and you have to have different screening pathways and tools in our system. Piping doesn't, we don't have the pipes right now that can carry the volume, so we have to re-engineer this stuff. And lastly, our HIT systems need to be different so that you need to be focusing not on 1.0 health information technology, but 3.0 is going to be about promoting optimal health. So how do you have our health systems that actually measure trajectories and cross-sector impacts and stuff? So we have to be designing the systems. It's like designing software. What do you want? Where do you want this to go? What do you want it to do? So I'm going to end the last 5 minutes here and talk about how this is actually being used. So if we're going to try and transform systems of care, how do we do this and what does it look like in early childhood? We have compelling brain science and compelling economics. That's just the Heckman curve, of showing the return on investment. But what we know is that every system is perfectly designed to achieve exactly what the results it gets. So if we want different results, you have to have a re-engineering process. And when we go out there in any community, you're going to have lots of programs out there. In fact, I would argue that we're program rich and systems poor. We have all these different things. And for a parent that needs services and has a kid with multiple needs, just as long as they go to this school and get a degree, and probably both a civil engineering degree and a social work degree, they'll be okay, right? They'll have the knowledge and skills to navigate this system. So the user interface sucks, right, in terms of them getting what they need. And what we've learned, it's not about the services, but it's about the systems. It's about embracing the complexity. It's about scaling the change that's needed. And it's about understanding complex systems learn their ways forward. So you have to think about what the learning system. And I would argue that this is the same whether you're doing HIV prevention, whether you're doing adolescent mental health, whether you're doing issues that have to do with falls in the elderly. It works the same for any of this. It's all a systems issue. And so if you look at in any community, you're going to have lots of evidence, even evidence-based programs, lots of people providing services. You'll have community-based organizations at a community level, so you have the hospital, the school, the WIC site, the various organizations. Then you have at the city or county level, you have these things. The problem is that these issues, with the way we think about them, they're the funding streams that make things happen and they make people do things. But this isn't a pathway down here. This is just a random set of services. And in fact, this is one big whirling vortex. It's like a weather pattern. And it sort of whirls around. And and none of the stuff is really linked up in any way to make it function in a user interface, and it doesn't function at any level. It doesn't function at the city level, it doesn't function at the community level, and it doesn't function. So what we need to be able to do is, how do you align the city and county departments, state departments? How do you get the community to work as a network? How do you get the healthcare and the early care and education, the WIC sites and the dental people all to work together, learn together, and perform together? And then how do you get care pathways that actually work for people so that you have a user interface? And part of you do this is through a learning system, through an integrator, through change management, through scaling change, through sustainability. So there are ways and tools of doing this. There are lots of places where we work with complex problems, and we've figured out ways of making things work. So when you go in and you're going to work with these different programs, and we want to start aligning the early care and education, health, family support, and child welfare, you need to figure out, how do we build a common agenda and a communications? So if we want to optimize trajectories, if that's our common goal, right? You're in health and you're in education, you're in mental health, you're in nutrition, you're in family support, we have to have a common goal. I can't work on self-regulation and you work on, reading scores and you work on developmental screening. Then we're all going to work on our own silos. We have to have a common thing that we're shooting for. And you need a common measure and a data system so you can hold each other accountable, and you need a learning system so you can all learn together. Toyota and IBM and Google, they don't have different systems in each part of their organization. They have a common learning system that they use to drive the change process. So we have to figure out, if we're going to align these things, what are the alignment tools and how do we go about doing it? If we're going to measure trajectories, what do we have to link our data systems together? And if we're interested at age 5 at school readiness, how do we measure that? So what we've been doing is using something called the EDI, the Early Development Inventory, which was developed in Canada by a noted mental health researcher, Dan Offord, and it's been used in Canada to measure children's development. It's called school readiness, okay? If you're in the health world, it would be called health-related quality of life of a 5-year-old. It's a global measure of how a child is doing. And it has extensive validity and reliability. It's filled out by teachers, so you take advantage of where the kids are at, And it measures all these things. It measures physical health, communication skills, language, but importantly, it measures social competence and emotional maturity, emotional development in children, which tend to be the things that drive everything. And what we've been doing is we've been measuring this all over. This is just part of Orange County, where we're measuring neighborhood by neighborhood the vulnerability of children. So this isn't looking Orange County-wide. This is looking in your neighborhood. Why is that different? Well, if I said Orange County-wide, or I said Corvallis-wide, or whatever it was, that 10 kids died in car accidents last year, we would all go, oh, that's too bad. And that's a statistic with a tear associated with it, and all of us will go out and get in our cars and not drive any differently. But if we know on Western and 26th Street that 2 kids died at that intersection in the last 6 months, what happens? We mobilize and say, how do we put something in place? So there's something about bringing data down to the neighborhood level and being able to do this. So what we've been doing, just briefly, we've been doing this across the country. So in the last couple of years, we've gone from 8 to 50 sites that are doing this across the country. And they're now formed a learning network, and they're all doing it for different reasons, but they're all starting to share their tools and share their learning. So New Orleans and Detroit and various other places. And I'm going to finish by showing you where this is being used and how it's being used to transform practice. Magnolia Place is a 5 square mile part of Los Angeles. 100,000 people live there. Very poor, very low resourced area. But the community came together and said, rather than us build a great early childhood program for 400 kids or 800 kids, how do we take care of the 35,000? How do we work at scale? So they're setting up 6 hubs. And think about this as Oregon. Think about it as your hubs that you have around, parent education and all your extension places. So they have these hubs, right? There's 71 partner organizations. There's 100 different community groups, and there's 500 block advocates that are being developed for this place, and there's 14,000 families. And people are coming together and working together and creating a learning system from different organizations to get the community-based organizations to work as networks. And they create driver diagrams. Any of you who have done quality improvement in engineering or in healthcare shows the outcomes, kids graduating from high school. Here's the EDI scores, profession and third grade reading. Here are things that you want to change. These will change very long-term, medium-term, and very short-term measures. So there's a whole measurement set. And then there's a set of drivers. And within each one of these drivers, there's all kinds of experimentation going on. So they're trying change practices and doing rapid cycle change, both around practice, leadership, and involvement. So if you want to do developmental screening better in this area, you have to have the leaders both in the WIC sites and the child care centers and the health care centers all coming together and saying, we want to do it better. How do we do it better? How do we change our practice? Go out and try stuff, come back, learn stuff, and you go through cycles of improvement. And we're using the EDI data to be able to map things and to sort of look at. So this is looking at the vulnerability of children, and this is looking at whether or not parents are reading, and this is looking at the communication. So that we're able to take the data and link it at a neighborhood level, and it brings people together. This is the accident on your street corner rather than the general. And we create parent surveys and run charts and dashboards so people can take collective action. So we're using what IBM would use or what Toyota would use or Google would use, but we're doing it in these neighborhoods. And doing community surveys with community dialogues with parents and driving a change process. And so just to finish, part of what we've done, back to my vortex of community change, is what we're trying to do is create a learning system so that we're trying to get alignment. We have an integrated network of people working together at every level and driving change. We have tools and analytics that we're using so that we can reflect back to what you're doing in real time and understand what's going on. And that we have this adaptive, flexible performance service pathways that we're creating, that they're creating, and they're learning their way forward and figuring out how to do it. And so, in conclusion, we need big, bold, transformative change. We need new ideas. We need to use new frameworks and new science and a new way of looking at things. We need to have the child health community commit itself to some kind of 2025 vision for what we need to get the children's health system to. We need to adapt this 3.0 strategic framework for our research and health system transformation, because I think where we're going to get the biggest change in the health system is not at the tail end of the lifespan, but early on, because people are coming together. They're understanding that early childhood is important, health and education. We have to take advantage of it. Your state could probably do more than any other state because you have a governor that understands this and wants this to happen. But he needs advice and leadership and research applied in information in a different way to make it happen. And we have to make the unavoidable, the unnecessary and catastrophic loss of health potential early in life an unavoidable and inconvenient truth for everyone. And we need some kind of child health futures network. And I would love for this center to join our centers and others, Christie's Center up in Oregon Health Sciences and others. We have to be banding together in collective action across this state and across the nation and creating the learning community so that we're actually doing this 3.0 research and making this work. And I just show this, that we have this life course research network that we have going on that several people here have been helping us with, but we have a lot going on about how we're moving this forward. So let me stop there, and I know I'm out of time, but if we have questions.
Thank you. You can see why Dr. Halfon is such a visionary in moving ideas across fields and fusing them and applying them in fresh ways to think about health and healthcare in brand new ways. We're so pleased that he's here today. We did get a few late start by a few minutes. I'd like to have a little time for Q&A, but if anybody's got a scoot, now would be the time. And I should also note that the students have a follow-up session with Dr. Halfon in about 10 or 15 minutes from now, also in this room.